medical aid fraud, waste and abuse is a multi-billion rand business, preying on an ever-increasing number of people who often are being charged for medical treatments and products they don't need and for services they don't receive. Despite being bolstered efforts by the law enforcement agencies and sophisticated software to detect the fraudsters and to crack down on the fraudsters, this phenomena of fraud, waste, and abuse continue to grow. That's why we are here to identify steps we can take to tackle this unwieldy beast. We need to come up with steps on how we can deal with these criminals, because that's what they are, who are intent on stealing as much as they can and as fast as possible, and who are prepared to fabricate diagnoses, treatments, even entire medical episodes.
According to the Council for Medical Schemes, 15% of medical aid claims are as a result of fraud, waste and abuse. Now, these false claims amount to between 22 billion and 28 billion rands a year. Now, up to 25% of all premiums paid by medical aid members are spent funding these false claims. Now, the CMS hosted about a week ago a 2-day summit on fraud, waste and abuse, attended by almost all stakeholders involved in healthcare in South Africa. Now, how much do we know about medical aid fraud? And what is the true extent of this problem? How does it impact the industry? And who's likely to commit medical aid fraud and why? And what is being done about it? So this is what we're going to tackle in today's show. Our topic is medical aid fraud, waste and abuse. And to help us unpack this, we have a guest panel and audience of industry stakeholders in this healthcare industry. Now, this is comprised of the chairperson of CMS, chief executive and registrar of CMS, MD of BHF, CEO of HFA, medical aid executives from Discovery, GEMS, Bonitas, Sizwe, MedShield, president of the HPCSA, consumer representative from Section 27, practicing medical practitioners from the IPAF and SAMA. Now, you can tweet us at SABC Health Talk or simply just interact with our Facebook page, SABC Health Talk. Now, sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Solomon Taung, and this is Health Talk.
What do you need when you cast your vote?
We need to have education.
We need a new model.
We need more justice.
We want to be employers.
We must clean up the ANC out of our system.
We are going to deal with corruption.
That's what we need to do.
For the answers, don't miss the all-new season of The Big Debate every Sunday at 7 p.m. on SABC News Channel 404 and SABC 2, starting 10th of March.
People ever come to you and be like, oh, praise God, hallelujah.
Someday will come and say, praise God.
Praise God.
Abantuan says what? Hallelujah.
Gospel of love is my love. You say, victory.
Gospel Unplugged, Sundays at 5:30 only on SABC 1.
You come across information about people using medical aids belonging to their relatives or others, and in the process defrauding the system. I got very discouraged when a head of Hawks, law enforcement agency, fortunately she's the former now, because of this, a whole head of Hawks forced her PA to use her medical aid, which was GEMS, on her behalf, on her relative, because her medical aid, being a police lady, was Polmed, and the fraud she was looking for could not happen in Polmed, and she had to be fired. She was our law enforcement agency. And you start wondering, what chance do we stand as a country if those people who must enforce the law are also in this type of practice? I've heard stories, I don't know, I haven't proven them, that our own Medical Scheme Act and its regulations are used to justify illegal activities such as coercion, entrapment, illegal camera placement in doctors' rooms, and other clandestine activities. Medical schemes and administrators cannot arbitrarily decide whose claims should they pay and whose claims should they not. There must be a clear, legitimate, and justifiable reason for the withholding of payments of claims or indirect payments through scheme beneficiaries. So the timing of this event came just at the right time, given the groundswell of support for anti-corruption, anti-fraud, and the good governance movement spearheaded by a person, no lesser than the head of state, the president of our country, President Cyril Ramaphosa himself. I am certain that all of us are aware of the multiple commissions and investigations currently underway to investigate and uproot fraud in identified areas.
Okay, so let's get straight into the subject of fraud, waste and abuse, and it's a great pleasure to introduce our guests for today. First up, closest to me is Lerato Musia. Now, Lerato is the CEO of HFA, and she'll tell us what HFA is. Welcome to Health Talk. Lerato.
Thank you.
And next to Lerato is Dr. Nozipho Sangweni. Now, Dr. Sangweni is the Principal Officer of Discovery Health. Welcome to Health Talk.
Thank you very much.
And last, certainly but not least, is Dr. Clarence Mini, who's the Chairperson of the Council for Medical Schemes. Welcome to Health Talk.
So, thank you.
Right. Perhaps let's start with you, Lerato. We're talking about medical aid fraud, waste and abuse, and for our viewers probably wondering, so what is the difference? What are we talking about when we talk about medical aid fraud as opposed to waste and abuse?
Thank you. So I just wanted to introduce the Health Funders Association.
Right.
We're an industry body that was established about 3 years ago, and we represent medical schemes, administrators, and managed care organizations in the industry. So we've got about 53%, we represent 53% of principal members of those entities.
And I suppose people would ask, so what's the difference between you and BHF?
Well, there isn't a difference in terms of what we are doing. We are working together in terms of building the industry, so together, with collaborating together, to make sure that we actually do have a bigger and broader strategy going forward.
Okay, so that said, what is then the difference between fraud, waste and abuse?
Okay, let's make the distinction. So fraud basically is, it's a criminal element. There's a criminal element to it, okay? And it's when you find service providers providing services and claiming for services and products that they've rendered illegally. And it should be then seen, obviously, different from what waste is, which is where you find over-servicing of those services or even of the products. So they're misstating the extent to which they're supposed to be servicing. Then when you come to look at abuse, for example, I would say anti-selection would be an example of abuse. So this is where you find that members or any other person out there abuses the system. And abusing the system would include things like, for example, joining a medical aid scheme for a specific period of time and maybe benefiting from the benefits from whatever it can offer for a period of time and then leaving the scheme. So that's where we would look at the differences of those. Okay,
let's get a perspective from a medical scheme, Discovery. Dr. Sangweni, what is the extent of this problem? Recently, there were figures quoted by Discovery to say this is what this is impacting us as a scheme. What is the extent of this problem?
At a macro scale, from an industry perspective, I think our regulator has observed and reported to us that the numbers are 15%, up to 15% of claims are fraudulent. that amounts to about 25 billion rand. And it's a significant amount of money. In our scheme, specifically in the Discovery Health Medical Scheme environment, in 2018, the amount of money that we saved and recovered from fraudulent activities amounted to about 500 million rand, 500 million rand. And we believe that in the past 5 years, we make reference to a halo effect. And a halo effect is that all the interventions that we put in place deter prospective fraudsters. Because of the interventions that we put in place, then they don't conduct fraudulent activities in our environment. And the amount on that front, from a halo effect in the past 5 years, in our environment, we calculate that to be 4 billion rand. So it's a massive amount of money. It has a direct impact on our membership. And as a scheme, our responsibility is to always protect our members' interests. And so we have a zero tolerance for fraud. And we go to extreme extents to address it and invest significantly in it.
Right. We're going to get into that a bit later into the program to see exactly how, we deal with this problem. But let's speak to Dr. Mini. Dr. Mini, we saw about a week ago, the Council for Medical Schemes, hosted this 2-day summit on fraud, waste and abuse. Can we just perhaps get a perspective into what was the rationale behind CMS, wanting in the first place to host an event like this?
Yes, thank you, Silo. What happened is last year as Council, we embarked on a roadshow to go and talk to and meet with all the entities that we regulate, that is schemes, managed care organizations and administrators. And without any exception, everyone that we interacted with raised the issue of fraud. And we decided almost halfway, we'd gone schemes, as you know, in number in South Africa are just 79 now. They used to be 80. When we started, in fact, last year, there were 80. We had seen 37 schemes. And we decided, before we even finish our roadshow, let's do something about this. And we decided to bring together all the players in the industry and say to them, let's do something about this. And indeed, the response was overwhelmingly positive. And we said, starting up front by bringing everybody together and getting to know what exactly do we mean by fraud? What do we mean by waste? Do we have the same understanding, or people have different understandings? So we formed a steering committee that agreed on these issues up front, and from there we decided we're going to have our first summit. And as the regulator, we want this occasion to be an annual occasion so that we're able to keep this thing in track, because it's got a possibility of destroying the industry. So
talk about destroying the industry. I mean, on a large scale, surely this is a problem that has a massive impact on not just the schemes, but the members as well. On a large scale, what's your view on the impact that this problem has?
Well, I mean, if private health care collects around 169, 170 billion rand, I mean, if this thing keeps growing, at the end it's going to eat up on all the resources that are needed for service. And we just think we have left it for too long without doing anything. I mean, the regulator on one side has been saying to people, please refrain from this, don't get involved. And we're speaking both to providers, to the beneficiaries, people that were there to protect. But we picked up that it's not one entity that is involved in this. There's quite a few players in fraud, waste and abuse. Okay. And we said, let's come together to fight it.
Okay, I believe we have somebody from the audience who'd like to say a word or two, yeah?
Yes, Jose Letlape from the Health Professions Council of South Africa. I just have a question to the panelist. What drives fraud? What are the causative factors? Because, I mean, for long we're talking about the symptoms. But unless you make a diagnosis and you deal with the root causes, you're not going to get rid of it. So I just wanted, since there's been a summit, was there any discussion and what are the drivers and the root causes of fraud, waste and abuse?
Okay. Thanks for that question, but I'm just going to ask that we park that for the next segment, because that's what we're going to be focusing in the next segment, to say what are the causes and risk factors for this fraud that we're talking about. Is there anybody else from the audience who wanted to say a word or two? No? All right, let's come back to the schemes then in terms of, you know, the patterns. We've heard of examples of what actually people do, and we know that this cuts across not just medical professionals, it's also members getting involved, pharmacists, hospitals. What trends do we see coming out, Loretta?
I think what we're seeing more of is there is more of collusion that is happening amongst the members themselves and the healthcare professionals, the providers of services and products. And you know, it's one of those things that you say you need to be able to catch the thief very quickly to curb the scourge. But what is happening is that they are actually, most of them are ahead of technology, and it is now posing a challenge also for the schemes or the funding industry as a whole to keep up to that. So we're finding that we're starting to develop more mitigating strategies that we need to embark on, and we're needing to find other ways of changing the mindset so that we have more of a sharing kind of culture. And so one of the trends is that we as you can see now, as Dr. Mini has said, we're meeting now as different stakeholders in the industry and making sure that we're starting to talk from one and be strong and start talking from one platform in terms of combating the fraud.
Okay, let's get the last comment from you in terms of you know, what you see within Discovery.
There's variability in regions. That's what we see. And so it is regional in pattern. But in terms of just as a general statement, we see about a third of the fraud coming from members, another third coming from corporates.
Corporates, what do you mean?
The big entities, the big providers. So those would be the corporates. And I think there's a misnomer in general conversation about fraud, that it's about doctors. It's not only the doctors that participate in this. You have the members, you've got the corporates, all participating.
All right. So on that note, we're going to go for a quick break. When we come back, we'll try and answer that question. What exactly drives fraud, waste and abuse? Please stay with us.
Makes me happy, gives me joy, sing hallelujah.
Do people ever come to you and be like, oh, praise God, hallelujah?
Some they will come and say, praise God.
Praise God.
Abantwana says what? Hallelujah.
Gospel of love is my love. You say, victory.
Gospel Unplugged, Sundays at 5:30 only on SABC 1.
When you put 5 girls against 5 guys, of course it's going to be lit.
Andile, what's the next challenge?
Witness all the fun, tension and laughs as we see how well friends know each other to win a luxury cruise. Join us as we bring the excitement every weekend at 6 p.m. only on SABC 1, Mzansi for sure.
Okay, welcome back. We're talking fraud, waste and abuse with our guests, and we're now joined by a different set of guests. First up, closest to me is Kenneth Murren. Kenneth is the Chief Operations Officer from Bonitas Medical Fund. Welcome to Health Talk, Kenneth.
Thank you.
Well, next to Kenneth, we have Tonishan Naidu, who is the Principal Officer of MedShield. Welcome to Health Talk.
Thank you very much.
Right. And, of course, sitting in the chair is Dr. Stan Malwabi, Chief Operating Officer from the Government Employees Medical Scheme. Welcome to Health Talk.
Good day, sir. Good
right.
Thank you.
Gentlemen, earlier on, somebody asked a question in the previous segment, and this is really what we're talking about, to say, What is driving fraud, waste and abuse? Let's talk about the risk factors. We've heard different, types of frauds that committed and so on, but what is behind this? Let's start with you.
Well, there are a number of factors, I think. First and foremost, the major risk that it drives up the cost of private healthcare or the price of contributions in belonging to a medical scheme. I think in addition to that, there are a number of other factors. It's the manipulation of tariff coding. It's probably gaps that are there in the rules and regulations of scheme benefit design. It's collusion between providers and members and other role players within the value chain. And those contribute to unnecessary costs in terms of your healthcare expenditure, eventually contributing to the cost of belonging to a medical aid fund. And if you can eradicate those unnecessary costs, it then makes the cost and the pricing of contributions much more affordable. The aim for us is obviously to increase the coverage. The industry has been stagnant in providing cover for approximately 8 million lives in the country, and we need to increase on that. And affordability is a key issue, and if we can eradicate that, then all well and good for us.
Jonathan, I mean, what he's pointing out, at least, is that sometimes benefit design, tends to encourage or, helps people identify areas where, they can possibly manipulate the system. What is your experience?
So I think, firstly, to set the story straight, there's fraud, waste and abuse is only perpetrated by a small segment. A large majority of healthcare professionals, members, are honest, ethical. Now, unfortunately, the small sliver of people creates a negative impression for the rest of the industry. But let's look at what's perhaps driving some of it. I think front and foremost is the mindset of that sitting in the members and the providers, that it's a victimless crime, which it clearly is not. It's not a victimless crime. The other pieces of the mindset which come to bear is that it's a grudge purchase. Medical scheme is a grudge purchase. You're spending 1,500 Rand. You want to make sure you get an ROI out of that at the end of the year. And then what people do is saying, okay, look, I actually have a target to reach every month, or to make sure I go and claim for glasses or I claim for things. And I think the other important factor I think we need to look at it is, while I believe South Africa has one of the best private healthcares in the world, we're still fragmented. Fragmented in the sense that a member could go to one doctor, they'll order medications, or they'll order blood tests, they'll order x-rays. Not a week later, they'll go to another doctor, and that'll be repeated. The x-rays, the blood tests, etc. And to some extent, there isn't sharing of those blood tests and x-rays, but the member still has to fork out money every single time for those type of tests, etc.
Right. Dr. Mlabi, I mean, on the member side, I mean, there's probably other external factors. We hear of these hospital cashback plans and members wanting to cash in. Just your quick views on that?
Well, with regard to that, I think it's a matter of the opportunity that is presented by the way healthcare funding is structured, in that the funding is largely by a third party. So a member goes to a health service provider to seek the product, which is health services, but doesn't pay immediately. There's somebody who's not part of that transaction who's going to pay, and there is no way of verifying, with in an absolute manner that actually this service was received, and as a result, when you pay, you are paying value for the service that was given. I think that is one of the biggest opportunities that presents itself. There may also be issues of trust. So these third-party payment arrangements are based on trust. So if you present your medical scheme card at the healthcare service provider, they don't necessarily always ask, are you actually the person who is on the card? And as a result, that creates an opportunity for fraud to be conducted. And I think it's one of the main reasons why fraud would be then undertaken.
All right, I believe we have Elizabeth on the line from the Western Cape. Elizabeth, welcome.
Good day, sir. How are you?
We're good. How are you, Elizabeth?
I'm fine. I just want to pose a question to the medical aid.
Yeah.
Why do we pay for the services that we don't need? For example, I'm a 51-year-old. I'm paying medical aid for maternity benefits. Really, the service that I will perfectly need, say maybe it's for the eye, for the specs, whatever, the coverage is very low. So why should I pay for maternity benefits when I need something else, then they cannot cover that fully?
All right. Thank you for that question, Elizabeth. Let's give it back to the medical schemes. Well,
first and foremost, I mean, the benefit design is guided in terms of regulations and what the minimum benefit requirements are. I think to the caller as well, one needs to take into consideration your own personal needs, requirements, what you require on a day-to-day basis, and choose your benefit package accordingly. There are options that, would provide a savings type option by way of an example, and you can actually utilize that according to your own personal requirements. Yeah. So I think it comes down to education and awareness and what your entitlement is. Okay. And schemes should address that accordingly.
All right. Do you want to add, if necessary? I'm sure it's well covered.
Just to the point that medical schemes in South Africa are constituted as a not-for-profit entity. And by regulation, we're not allowed to discriminate. We have to ensure that we charge the same price for the package, irrespective of the person. Yeah. So, and that comes with or without the benefit.
Okay. Perhaps just back to the audience. Somebody asked a question, but what was the idea behind the question? But I'll come back to you. But let's hear what the person with the mic says. Yeah.
Yeah. I'm Dr. Elijah Nkosi from the IPA Foundation of SA. It's really more of a comment about fragmented care, and that in actual fact, if the GP or family practitioner could be made the coordinator of care, and the patients urged to choose a provider who will then ensure that that patient, uses medical services correctly and doesn't go directly to specialists. And in actual fact, we even have a peer review process where we get this data from schemes and we're able to see who the outlier is, and we have a mentoring process to ensure that those costs, that wastage is actually reduced.
Yeah. All right, just pass the mic over to Dr. Letlape. Yeah.
Khosi Letlape again from the Health Professions Council of South Africa. Just want to go back to the things that were said from the panel. The issue about lack of coordination and not being able to get information. Isn't the fact that you have too many administrators that work in silos not a thing that aids corruption? Because a person can be taking 10 rands from each of you and being overpaid. And the amount that they are being paid, they need to be working, 72 hours a day to be able to see those patients and make that money. Is this fragmentation not aiding fraud so that it can be detected? Okay. And we always talk about fraud, abuse, and wastage. Now, if the purpose is the same, is it not a waste to have 57 different administration systems that can't even get on top of the game? When if we had a common platform, it would cost less. And you'd be able to see fraudulent practitioners and fraudulent corporates fairly quickly, because you have the norms and standards and you have common sharing of information on any practitioner, on any practice, and on any hospital.
All right, Dr. Letlape, thank you so much for the questions. This is all the time we have for this segment. We're going to come back and have comments on that question. But for now, time for a quick break. When we come back, we'll continue our discussion on fraud, waste, and abuse. Please stay with us.
Get the facts first.
In 1994, I think was ons almal was ek ook baie excited geweest.
For South Africa, art was never a good thing.
From a footballing point of view, there was never a separation.
Get to the truth.
There's still some serious issues in South Africa.
Maar ek dink die regering kan regtig probeer om harder te werk om
ke apartheid in Sutlile ke le ke sola ke batho ba rena ba democracy batho ba batsho e seng makgowa.
See what it all really means.
Ek is geel, want dit is die kleur in die verkeerslig wat vir jou sê wees versigtig.
I still give South Africa red.
We are somewhere in between.
We're giving our democracy a green for sure. We're very happy.
But God,
Democracy Gauge, weekdays at 5:30 on SABC News, Channel 404.
We are at the forefront of Africa's tech discussion.
We're already planning for the 5G spectrum to be licensed by 2020.
In Mauritius, for fiber migration, we had a strategy. On network, we have gadgets, robots, and more.
We focus on investing in entrepreneurs and technology in emerging markets.
There's technology and social media news on Network with me, Spomenele Zondi, every Saturday at 8:30 p.m. and every Sunday at 5:30 p.m.
It is worrying indeed when any publication has to close down. So it is really getting tough from the point of view of lack of sufficient readership to the issue of social media.
How influential is the media still? Twitter, Facebook are influencing people far more than mainstream newspapers nowadays.
The media has greater responsibility compared to Twitter. The media itself is governed by certain codes and it must abide by those codes.
Threatened, attacked and killed. Journalists are also being imprisoned in record numbers around the world.
If you mention and name particular journalists, you actually put them at risk.
We were media activists, and I believe we still are today. A journalist is an endangered species today.
Watch Media Monitor Sundays at 9 a.m.
Okay, welcome back and thank you so much for staying with us. Today we're discussing medical aid fraud, waste and abuse. And if you've just joined us, that's our topic and please just stay tuned. We're going to introduce a new set of guests. First up, Dr. Ismail Rasool, seated close to me, who's the Chief Data Officer from Discovery Health. Welcome to the Health Talk, Dr. Rasool.
I'm not a doctor, by the way, but thank you.
Well, okay. So for the purposes of the show, you will be a doctor. All right.
You.
Next to Ismail is Dr. Elijah Nkosi, who's the CEO of the IPA Foundation. Welcome to Health Talk, Dr. Elijah Nkosi.
Yes, thank you.
And of course, as you've already heard, this is Dr. Khosi Letlapi, President of the Health Professionals Council of South Africa. Welcome to Health Talk formally.
Thank you for the invite.
All right.
And, afternoon or morning or afternoon to the viewers.
Afternoon indeed, yeah. All right. So let's get back to this. I mean, we've tried to understand what is it that causing fraud, waste and abuse to then say, okay, how can we deal with this problem? And perhaps let's start with what it is that we're doing to deal with this problem. And you can look back as far back as you want. Let's start with you, Ismail.
So I think I'll answer it from Discovery's perspective. I think, first of all, we do see it as an important moral and social good that we need to address the problem. We're spending an enormous amount of money, people, resources on trying to detect patterns where claiming patterns are out of line with the norm, and we're investing in sophisticated software to do that. So that's one element, detecting it. We have a whole team that then goes and verifies what's being detected. And then we have a team that actions how to then prevent it. So that in a nutshell is our ecosystem, and we remain committed to dealing with it for the sake of our scheme and our members and society at large. And you're right, you can go many years back and tell almost a similar story in terms of what has medical schemes been doing about it. The short answer is we've been working hard to try and make sure that schemes and societies don't pay for more than what they should be, particularly when there's corruption and abuse and waste.
All right. I know that Dr. Letlapi, posed some questions earlier on that perhaps we need to address. I mean, very valid questions around, fragmentation and so on. We need to address that, but I want to see if from the audience we have somebody else, perhaps from one of the schemes, to then give us a sense of what is it that is being done about this problem of fraud, waste and abuse. Do you have somebody?
Yeah. Thank you. My name is Ishmael Mohapi.
I'm coming from the government's employees medical scheme. The first step that we've done, we held a summit where we actually signed a fraud, waste and abuse charter. And secondly, what we're also doing is that we are encouraging collaboration between the schemes and administrators. And currently we have a tool that is which we are using, which is called an HFMU portal, where schemes can share data in terms of anomalies, their investigative finding. And with this, we're hoping in the future that we will have readily available data which can immediately detect when there's an instance of fraud, waste and abuse. So we are encouraging that all administrators and schemes to participate in terms of the sharing of information so that we can address the same question which Dr. Clapper has raised. Thank you.
All right. Let's come back to you, Dr. Nkosi. I mean, we've heard about what the schemes are doing and how they're dealing with these problems. And oftentimes it is really what are they doing to the practicing medical practitioners like yourselves? I'd like your views from a perspective of a practicing medical practitioner.
Yeah. Well, as an organization, the IPA Foundation, we don't condone any fraud, waste and abuse. So in terms of communicating with our members, we do, let them know what that position is, and we send newsletters to them. Yeah. And we educate our members. Yeah. But what we are against is when now there's suspected fraud, and the schemes send in their fraud investigation units, which don't even make an appointment with a doctor. They show up and they raid the premises, want to see patients' records, and force doctors to sign acknowledgement of debt that they have to pay over a period of 5-7 years. And when they, come with this AOD, they would then say this practice has been happening over the past 3 years or 5 years, and then claw back. What we are saying is that where the suspected fraud, that case has to be either sent to SAPS and reported to the HPCSA. And where there's waste and abuse, we've got a peer review process where the data is profiled. We're able to see where there's wastage or where there's antibiotic abuse or where a suitable generic could have been used. Yeah. So in those instances, we're able to advise those peers who are outliers.
Okay. I'm gonna come back and let the schemes respond. Yeah. But now that you've mentioned the HPCSA, perhaps let's put the question to Dr. Letlape. Are there cases that are referred to the HPCSA around, fraud? And if so, what are you doing about them?
Yes, there are cases that are referred for fraud, but it poses serious challenges because of conflicts of interest. And some of the cases that would be referred of major fraud, the scheme would be interested in cost recovery. So they make our job difficult. They go into agreements with the practitioner where they keep the practitioner alive because they want their money back. And it prevents us from getting rid of that practitioner. So in a sense, it becomes like the fraudulent practitioner goes into partnership with the fraud unit of the medical aids. They have the resources. If they ensure that fraudulent practitioners were prosecuted to the full extent of the law, it would help us eradicate the problem. Okay. Because we would remove them from the register. Yeah. Now, there's this action of, as my colleague talks about, of unlawful actions, sting actions, not using the legal authorities for those operations. And because they've acted outside the law, and they want to get the money back, they act like bouncers in a nightclub.
Is that what you do?
Outside the law.
Is that what schemes do?
No, and so that disempowers us from getting rid of those practitioners.
Yeah, but
because
these are
made
serious
side
allegations, Dr.
and it becomes a problem.
Let's give them an opportunity to respond.
No. Maybe let me explain myself before they respond.
We just don't have
when
enough
they
time.
do their sting operation, it is not authorized by the NPA.
Okay.
Now, in this country, that's acting unlawfully.
All right.
So I just want, so that there's a proper context about the things that I say.
Ismail?
So I think, obviously, the doctor has quite strong views on it. I think, first of all, we have gone through enormous legal opinion to ensure that what we do is completely above board. And it's something that's not new. We're not doing it just, over recent years. The process and the methods have been there for years and years. And I can tell you with hand on heart that we do everything above board according to what the South African law allows.
Any other comment from any of the schemes? Yeah, somebody, yeah.
Okay, thank you. From Ishmael Mokhapi from GEMS. I think also there was a call, and we've listened to what the industry say. And also, I also invite the HPCSA to be part of what we'll be doing with CMS. We're going to be drafting a code of good practice, which will guide ways in which forensics investigation are done. And also we invite the association to also partake in that process. But also what I can say is that everything that is done according to the law. Whenever we have entrapment, they are done by the police. We do everything by the book. And we have cases that have been where we have been challenged legally. And all those cases we've won. So the idea is that we need to collaborate with associations, and we need to draft that code of good practice so that we can.
All right, we'll get more into that in the last segment. But just pass the mic to the back because somebody would like to.
But Silo, you're not being fair.
Yes, and I'll come back to you, Mr. Litzler.
Thank you so much. This is Mvuisi Mzukwa. I'm the National Vice Chair of SAMA. I just want to pose a question on how we deal with fraud, waste, and abuse. I don't hear anything about dealing with the current options that are dished out by medical aids, which are encouraging fraud.
Yeah.
Secondly, I don't hear any involvement of the HPCSA in the plan that the schemes are saying. Are planning to deal with this matter in the future. I don't see the role of HPCSA yet. The providers, if we speak doctors, there must be involvement of HPCSA, and also providers must be part of that, because what has been happening is that there's been this fragmented approach to wanting to deal with fraud, waste, and abuse by the schemes as well. So I think there should be a coordination around that.
Yeah. So clearly there are problems on all sides, and it's time for us to look at a solution going forward where all stakeholders are going to get together and, of course, work towards a common solution.
But
on that
note, no, before you disappear.
Time for a quick break. When we come back, we'll continue our discussion on fraud, waste, and abuse. Please stay with us.
Witness the exhilarating drama between the Morokas and the Mabasos in Generations The Legacy. Weekdays at 8 p.m. on SABC 1. Mzansi for sure.
This week on Trends Travel, we take you back to the 70s and 80s, where Italian fashion influenced the fashion scene and how it continues to inspire how we dress today. We also visit a distillery in Limpopo where creating your own drinks can be a lot of fun. Also on the show, Black History is celebrated in the form of an art exhibition showcasing artworks of Black South African artists dating back to the 70s. For all this and more, tune into Trends Travel this Saturday at 5:30 p.m.
Azikho izinto ezibuyisela ubudlelwane emumva njengamanga nezimfihlo.
Ungakhulumi amanga, khuluma iqiniso.
Uthi wajila kanye kuma Edmond and kungenxa into wena wayithethayo.
Usandile unamanga.
Wabamba red-handed embhedeni. Peteni. Benqunu. Ngixelele Edmond lana ubunixela nalapha wathini kuwe.
Ungaphuthelwa umxazululi wezothando kunyanyana njalo ngoLesibili ngo6 ntambama la ku SABC 1 Mzansi for sure.
Tandega, her weird family and cray-cray friends bring you another cheeky season.
Everything new, brand new. Well.
Into zami ke la.
Tandega bengikhuluma nomaziputhe efonini uthi ucela space back. Ithembe mem, ha ke tshepe motho. Awe, nkampa ka tshepa lejwe. Yini? Sizathu ukufunda la esikoleni, are you aware? Yeah.
Eyamugele. Catch Tandeka's Diary Mondays at 7:30 only on SABC 1 Mzansi for sure.
The signing of the charter will represent a big step forward for this industry with respect to combating the maladies that we are faced with. Because otherwise, if we don't do so, we'll find ourselves moving out of the crisis of fraud and corruption.
Okay, welcome back, and thank you so much again for staying with us. We're discussing fraud, waste, and abuse. Let me introduce a new set of guests. First up, Dr. Katlaho Mutudi, who is the MDA of BHF. Welcome to Health Talk, Dr. Katlaho.
Thank you, sir.
All right, and then we have Dr. Angelique Kutsie, who's the chairperson of the South African Medical Association. Welcome to Health Talk,
Thank you.
Kutsie. And of course, we have Dr. Sipho Kabane, who's the Chief Executive and Registrar of the Council for Medical Schemes. Welcome to Health Talk, Dr. Kabane.
Thank you.
All right, so Dr. Kabane, perhaps let me start with you. We've just seen in this clip the signing of this industry charter. Please take us through what that meant and what's the way forward from here.
Well, the signing of the industry charter on anti-fraud, waste and abuse is basically the first step. Because within the charter itself, there's a set of principles where individual, industry players are committing themselves to these anti-fraudulent and wasteful activities. And it sets the scene for the entire industry to now develop standards and codes of best practice for each and every player, so that when we adjudicate cases and we're addressing complaints related to this, we're able to say who's playing according to the rules and who is not. But obviously, we're aware that there are a number of players in the industry that have not signed the charter yet, and we want to encourage them to come and sign, because after this process is completed, there'll also be a process of developing comprehensive industry-wide plans to address specific fraud, waste and abuse issues, and also to ensure that there's collaboration between the various regulatory bodies.
Yeah. I mean, clearly, as you've seen, I mean, there are issues that have been raised with a bit of passion, from all sides. Is this charter one way of addressing this issue, to say, let's have all of these, put into a document so that we have standards going forward? Yeah?
Yes, the charter itself contains broad principles, like I said, out of which you can then start to address specific, issues. For instance, the conduct of schemes and administrators in the detection and the management of fraud. If that could be standardized, then it could go a long way towards making sure that those practices are lawful.
Yeah.
The conduct of members of schemes, across the industry. What would be the best practice and standards that we want to set for, or they should set for themselves, so that when they conduct fraudulent activities, they are able to take, the consequences that come with that.
All right.
So in a sense, it's to step up towards setting up rules for all the key stakeholders, so that we're able to deal with the scourge in a much more direct fashion.
Let's talk to another stakeholder, BHF. What would you like to see going forward?
As Dr. Kabane has said, I think the charter is a great way to start. Of importance to us is the issue of collaboration. We've been saying for a long time that fraud is a challenge not to one scheme, not to one entity, but to the entire industry, to the entire sector. So it does not make sense for us to work from different quarters. So we need to collaborate and collaborate on many levels. First, setting up industry standards for conduct, but also starting to work together, sharing of data responsibly. And then also, at some point along the way, we must talk about the other industry issues that maybe are not directly linked to this but could have a consequence in fraud. Things like billing, tariff determination, etc. And once we start dealing with those issues at an industry level, not as an entity level, and not in a competitive way, we will start making inroads. The issue of fraud separated from the waste and abuse, it's criminal. And what we need to do is just strengthen our relationship with law enforcement. I think in a lot of cases there's frustration on the part of schemes, that there are cases that are reported either to the councils or to the police, but they do not find traction simply because we do not, one, know how to prepare cases.
Right.
So there's an education element that is required. Right. Also on the other element, there is a poor understanding of how schemes work, and it is necessary that we also collaborate with law enforcement.
Okay. Let's get a view from the practitioner side now, Dr. Kutsia.
Thank you, Silu. From SAMA's side, SAMA is a membership organization, and SAMA was one of the parties that didn't sign the health compact yet, and we think or feel that there was not enough input given from our members. It was too short notice to get the input from our members. So once we have the input from our members and the buy-in and tell them how we see this whole process, we will come to the party, because we do see fraud, waste and abuse as a huge problem and challenging the current private sector industry. It's not only in the private sector, I must correct myself, it is all part of the public sector. But looking forward, what we would suggest as well is start looking at benefit designs. The benefits designs currently do not favour primary health care. It's more orientated to tertiary health care.
Yeah.
Start training the undergrad students in what is practice management, looking at the buy-in of all the role players out there. It should be, the patient should be included in this.
Okay.
It's no use only getting your service providers up to standard, but your industry as well.
Let me go across to the audience and see if we have one or last, let's start at the back. Dr. Mazwai.
Thank you again, Dr. Mazwai, Sizwe Medical Fund. I'd just like to draw on a comment that was made already, that while there is an intense focus around the providers that are involved in fraud, waste and abuse, that the industry needs to respond to the broader set of people who are involved in it. And that's administrators themselves. They're people within administration who are complicit in fraud, waste and abuse.
Yeah.
It's members as well. So it's a broad spectrum. And I just wanted to sort of illustrate, or rather to bring out the point that we as an industry need to respond to this. I think what I like about the charter, and whether there is signing of it or not, the fact that you're on the show, the fact that you're part of this conversation still shows a commitment to being a part of that process and making sure that we do have very transparent, very clear manners in which this industry can address this. In the time that you've had your show, Dr. Mataung, about 2.8 million rand is being lost to fraud, waste and abuse. And I think there is an urgency for us to address this matter.
Before I give Dr. Letlape a chance, I'd like to hear from a consumer perspective, perhaps Section 27. Sorry for putting you on the spot, but I think it's important to hear your view.
I would like to first say that we acknowledge...
And this is Nkululeko
from Section 27.
Right.
I'd like to say that we acknowledge as a starting point the summit and the aims of the summit, together with the Competition Commission's Health Market Inquiry. So what is quite clear is that there does need to be access to information, and members need to feel that they are co-owners or owners of their scheme. And part of the reason for fraud is that members don't feel a sense of ownership, or they feel that they're taken advantage of.
Right.
In addition to that, we would also like to point out that we must, in addition to looking at fraud, waste and abuse, look at other factors. So anti-competitive business practices and the effects of the fraud, which ultimately place a burden back on the public healthcare system, which private healthcare is meant to alleviate.
All right. Thank you so much. Dr. Letlape, we have exactly 1 minute left.
I think still what we have is a system failure.
Right.
And the victims of the system failure are the honest members of schemes and the honest practitioners. The crooked members and the crooked practitioners are the beneficiaries. And those that are administrating right now on their own are unable to do that. If there's no commonality and working together, we'll never get on top of this problem. And there are other issues where, the minister talks about a commissioner that's looking for care for a family member and resorts to fraud, despite the provisions of Section 27 of the Constitution. Now, if that person had access to care as our Constitution mandates, that commissioner would not resort to fraud to aid a family member. There's a system failure. There's too many disparateness. If you look here, the abuse of all these administrators having their own corps, their own system, we could work on one admin platform, like ATM machines across banks. Doesn't exist here. And it's spending the healthcare rent.
On that note,
Patience,
I think that's all we're going to have time for today. And to you folk at home, thank you so much for staying with us. We're back on your screens again next week, same time, same place. And until then, please do take care.